So, hello everyone. On behalf of the National Alliance for HIV Education and Workforce Development, also known as NAHUD, I would like to welcome you to our monthly webinar series and thank you for participating. Before we begin, I would like to review some housekeeping items. First of all, we invite you to use the chat to engage with your fellow attendees. We have put a chat waterfall in there, so we go ahead and ask to put your name, your organization, and really what interested you about today's topic. Today's session is being recorded, and the session recording and a PDF of the presentation slides will be added to NAHU's website as a resource. You will receive the information in the post-webinar email that will be sent out through Zoom. You can also visit NAHU's resource page on the website to find this resource and view the past sessions. So throughout the session, we ask that any questions you have for our speaker, Alex, that you go ahead and use the Q&A pod, and she will address them during our Q&A session towards the end of the today's webinar. As an alternative, if there's time, if you feel more comfortable raising your virtual hand, we can open during the Q&A session, we can also open your line so that you can ask Alex your question live. So the speaker, okay. So without further ado, I want to go ahead and give some background on NAHU for those who are not familiar with us. NAHUD is a membership organization of 8 regional and 2 national AIDS education and training centers, also known as the ATCs. Established in 2010, NAHUD supports the ATCs, a component of the HRSA-funded Ryan White HIV/AIDS program, which have an explicit directive to build and maintain a well-educated and culturally sensitive health professions workforce that can provide prevention, diagnosis, care and treatment, and medical management for people at risk for and living with HIV. NAHU collaborates with multiple organizations to promote and educate on the work of the ATC program. Since 2018, NAHUD has been funded by the American Academy of Addiction Psychiatry as a partner organization of the Opioid Response Network, also known as ORN, to address the intersection of HIV and opioid use disorder. ORN was created to support efforts in addressing the prevention, treatment, recovery, and harm reduction of opioid use disorders and other substance use disorders through the provision of locally designed education and training. So we invite you to visit the website to submit a technical assistance request, read case studies, see featured resources, check out upcoming ORN events and trainings, learn about ORN work groups addressing health disparities, and more. So we really value and welcome your feedback on today's webinar. We will include a link to the evaluation towards the end of the session, and it will also be included in the post-webinar email. If you are looking to receive credit for today, we are accredited for CME, CNE, social work, and we're able to offer a certificate of attendance if you prefer. So if you are requesting CE, you will need to complete the evaluation. And just know the evaluation is super important for us. We use that information to help us guide our next sessions as we move forward with our series. And we also provide that information to our speaker. So we go ahead and invite you to complete the evaluation. So once you complete the evaluation, please give us about 3 weeks, up to 3 weeks, to process your request and email you your certificate. If you don't receive it, go ahead. You can reach out to me and we'll go ahead and make sure that you get it. But any questions, always feel free to reach out. At this time, it is my pleasure to introduce today's speaker, Alex Dittmore. Alex has been working in the field of direct care services since 2014, starting in inpatient mental health and group homes for adolescents. From there, she began organizing and educating at the peer level on harm reduction surrounding drug use, as well as sexual health and consent. Her work in harm reduction direct care services began in 2017 and includes conducting and leading street outreach services, managing a drop-in center for people who use drugs, overseeing and administrating sexual health services, and reporting on multiple programs while providing supervision to people with lived experience and those who are actively using drugs. As part of the national training team with NHRC, she has consulted and facilitated training on overdose recognition and response, motivational injury, risk reduction, crisis intervention, and de-escalation, and best practices for working with people who use drugs, sex workers, and people experiencing homelessness. So at this time, I'm going to pass it over to Alex.
What A mouthful. You did that so well, Liz. I forgot what I wrote for that. Hello, hello, good morning, good afternoon, good evening, depending where you are. Thank y'all so much for dropping in, not only your names, but where you're at. We have such a vast variety of people here today from so many different places, so I really appreciate that. And thank you for the intro, Liz. Again, hi everyone. My name is Alex Dittmore. I use she, her pronouns. I am a housing and shelter capacity building coordinator. Very fancy name, right? At National Harm Reduction Coalition. That is my single disclosure for you. I'm not connected to any other programs financially, board-wise, anything like that. I work for National Harm Reduction Coalition and that Trainings and Technical Assistance Center. And I'm part of a really good network of people, right? That not only do this work, but are also connected to folks on the ground, right? Working with those direct care workers that I have now pivoted out of into just consulting. We have a lot to get through today. We're going to have a Q&A portion. I highly, highly recommend use the chat. I've attended these trainings myself throughout my entire career, and it's really helpful to get connected to other people both around you as well as in other states, even countries, because you need a lot of thought partnership, right? This work can be very isolating. We can work in silos, sometimes purposefully, sometimes not, because there's so much work to be done. So I really recommend engaging in the chat as well as using that Q&A portion. Everyone will get access to these slides. I will also give you my contact information. So if you have questions, comments, concerns, you want to ask me something else, ask me if I know someone who can help with this, please don't hesitate to reach out. Truly, a big part of harm reduction is coming together to actually work, right? Because not every program can do everything. If you hear my dog crunching on her breakfast in the background, I apologize. So our objectives today, just very quickly, we're going to be talking about what is kind of the current state of HIV, what are some of the numbers that we're seeing that have come out from the CDC, as well as what are some of those health disparities, right? Both with age, as well as racial ethnic disparities, as well as folks that we really need to prioritize when we're talking about outreach, things like that. We'll get more into the nitty-gritty of substance use, as well as some research about youth substance use specifically and youth behaviors. And then, of course, I'm going to be leaving you with what is harm reduction? What are we doing with it? How do we meaningfully engage youth in harm reduction and risk reduction? A glossary, I offer this to you. I will not be quizzing you. However, our work is filled with acronyms upon acronyms upon acronyms. Our language changes in this field all of the time. So I think that this is always just helpful for people. Like I said, you'll have access to the slides. So I think that this is just nice because when you see all of these things in these reports that come out, a lot of times they assume that you know what it means, that you know what all these acronyms mean. And we don't always, right? So hopefully that this will help out with some of it, right? Okay. So from the CDC released 2021 is what we have the most up-to-date standard actual numbers on. And what we had was about 32,100 new infections. Currently, though, in the United States, we've got about 87% of folks that are living with HIV that have actually received a diagnosis. So that means that 1 in 8 people in the United States that are living with HIV do not know it. I'm sure I am preaching to the choir to everyone here that we know that we absolutely have to do better about making sure that we're getting people tested, getting them connected to care, so on and so forth. There are so many fall points when it comes to the continuum of care like this, right? We saw a huge surge in at-home testing during COVID, which is wonderful, very accessible, and comes with its own issues and complications, right? People receiving results at home, not having as many people depending on the programs connecting to them, being able to engage them in care. What do we do when we're finding folks that are falling out of care, so on and so forth. One thing to note, though, is that there was actually a 34% decrease in new infections amongst people 13 to 24 years old. And almost most of that was from gay and bisexual men. In this world of HIV, we have, from the beginning of its conception, right, in the late 80s, really hyper focused on what we call MSM, men who have sex with men, which is already pretty narrowing language, right? Because it has to be self-identifying. Then we're also identifying someone by one behavior as opposed to the breadth and spectrum of their behaviors. So I think it's important to note that, yes, we have done phenomenal work with increasing that awareness, increasing accessibility to testing prep with that population. And we want to make sure that we're reaching everyone. because we see increase in heterosexual folks that are having new HIV transmissions because they think that this doesn't apply to me as much. I love a good graph. I think that it's very helpful. I try to have a mix of text as well as visual components for people. So that way you can really like see, grab some numbers, get a chance on what's happening. So for ages 13 to 24 for 2021, pardon me, we had 19% of folks that were new HIV diagnosis in this range. The biggest was 25 to 34, right? So seeing this kind of like drop in these older populations is great, but we really want to focus on youth as well as this young adult to like mid-adult ages. I think it's important for us to see what are things actually looking like, because the reality is we get a lot of information all of the time from many different places, and a lot of it is very fear-based, very fear-mongering. So we're going to kind of look at what is actually occurring as opposed to just our anecdotal knowledge, which is incredibly powerful, but it's good to pair it with some good old statistics, honestly. Now, bear with me with this slide, okay? So I said already that male to male sexual contact, the whole MSM thing. And I use that quotation because I wonder how we're going to move through how we scope HIV and how people are attaining it as we move forward, right? So we see it as 66% still leading in it. Heterosexual contact, 22%. That's gone up over the years. And injection drug use is actually at 8%. I think a lot of times that folks really hyper focus on injection drug use, thinking that it's got to be so much higher. But the reality is, due to harm reduction programs, we've been able to reduce some of that, having access to sterile supplies. So that way you don't have to share. That way you don't have to share any of your supplies. You can have your own. Access to treatment, access to testing and screenings in general is very, very, very beneficial, because sharing injection drug use equipment is a very easy way to transmit HIV. The barrel of a syringe is a very unique, moist environment where HIV can survive a bit longer. HIV normally, very fragile type of virus where hits air, dies pretty quickly. But with injection drug use specifically, it increases that risk because you have blood-to-blood transmission directly, right? Much more intimately so even than sexual contact, for example. But even with that, we still see 8%. Men have a little bit higher rate of it for folks who inject drugs, women as well. Data is very, very binary, particularly with gender. So I really just say that so that way we can know, anytime you look at data, take it with a grain of salt, because this is self-reporting. You really want to look at sample sizes, things like that. Think about, these are just reported cases of HIV, and reported activity, things that we're engaging in. Some folks may not share everything that they engage in, right, when they are receiving a new diagnosis. So just think about that when we look at our data. It's beautiful, it's important, and it's imperfect. Now, this is where my nerd brain goes out for numbers, right? Which is, what are people doing? I'm very interested in behaviors as someone who does risk reduction. I'm incredibly interested in what types of behaviors are people engaging in. What you're going to see a trend with is younger folks normally engaging in a bit higher risk behaviors. So that 18 to 24 range, for example, this is predominantly looking for people who are injecting drugs who do not live with HIV. So for folks who are not living with HIV already, you have about 60%, so more than half of them, have admitted to sharing a syringe, using a syringe after someone else had used it within the last 12 months. And then when it comes to sharing syringe equipment, so not just a syringe, but maybe like cookers, cottons, waters, things like that, depending on the supplies that you have, that also goes up. So 18 to 24-year-olds, we're saying about 48% of them used a syringe after someone else used it. And conversely, talking about any injection equipment really spikes it up even more so. 72% have admitted to sharing some form of injection equipment. And though today our focus is HIV, it's very important for us to note that like hepatitis C is a very strong virus. Hepatitis C stays alive a heck of a lot longer than HIV, and is something that also is very easily treatable and is actually just completely curable at this point. We're luckily not in the days of interferon anymore, where you're on medication for over a year and it has a chance of really not even working and really feels like crap when you're engaging in it, right? but looking at what are our behaviors. So seeing, as you can tell by these numbers, that younger folks tend to engage in those behaviors a bit more. And why might that be? Is it because they're young? Are we really going to focus on that prefrontal cortex part? Or are we also going to focus on the stigma and the inaccessibility to services as well for young people? Good old Yuri Bronfenbrenner. I think that this is really important to focus on when we're talking about why people engage in the behaviors that they do. So Yuri Bronfenbrenner, psychologist, who really talks about the impact of these micro, meso, exo, macro, and chrono systems. Very academic language to say, how is an individual actually influenced by their surroundings and how do they intertwine and intersect with one another? So you have the person, you have their friends, their school, their family members, the cultures that those bring in and of themselves, and those interact with things around them, right? It interacts with their local government, it interacts with media, the media they consume, which then goes into political systems, their community culture, as well as just the culture of where they live, building further and further outward, and then the time that we're living in, how things have changed, right? How the stigma of HIV is still very much alive and well in 2024 and still quite reduced from how it was, let's say, in 1988, 1993, even 2000, 2004, so on and so forth. Though we've come a long way with stigma, it's still, I think, important to note that we do have folks that genuinely think that like HIV can be passed through saliva. We have folks that are passing away from complications with AIDS because they're not accessing HIV treatment, even though we have such a breadth of treatment now. So what types of things might impact our behaviors? What things about our cultures and how we're raised might impact what we engage in, what we think about these things, right? So some unique considerations for youth, and honestly, this applies for everyone, but I think also we want to look at some of the stuff specifically for young folks. So familial history of substance use. What is the culture of substance use in the home? Is it heavily stigmatized and demonized? Is it even spoken about openly? Is there history of substance use in the home? Is there history of HIV? Like, are there folks in the family that are living with HIV? I grew up in a family with an aunt who was living with HIV, so it wasn't as stigmatized for me growing up. It was something that we spoke about. It was spoken about how it was transmitted, how she had it, and how she ended up unfortunately passing away from complications with AIDS in the 90s. So for me, it was very, very different, right? Compared to many of my peers, we didn't talk about it. That was seen as something very, very scary. And also, frankly, a lot of people thought that it was really just accompanied more for gay men specifically, which we know is not true. Of course, anyone can get it, right? Legal considerations. I see a lot of different states that people are coming in from, as well as even some countries. Shout out to y'all from other countries attending this. Thank you. But think about like what are the actual laws, because it's going to be different. Family planning, so like STI testing, HIV, hepatitis C testing, it tends to fall under that family planning for the most part. So like Connecticut, for example, that's ages 13 and up. So you can go and you can access HIV, hepatitis C, STI services without parental consent at that age. You can receive sexual health services at that age as well. Where it gets a little bit trickier is when it comes to substance use treatment. That is very, very dependent on age. A lot of times you have to be over 18 in order to not have, obviously, parental knowledge of it. Many times it has to be under, but that's more in the treatment lens. So if we're talking detox programs, methadone, Suboxone, things like that. But just talking with young people, you can talk about substance use and about youth who are engaging in substance use at any age. My first professional job in this field was with an AIDS service organization where I actually did nothing but like sex ed and consent workshops at high schools and at middle schools, college. We did testing at the colleges and so on. This is something that we need to be talking about with youth, right? What can we do with parental consent, without parental consent? And like I said, that culture of the community as well. What education do these youth have access to regarding substance use? What is the messaging that is being used? Is it strictly dare-based, where we're just saying that drugs are bad, they're going to fry your brain like an egg in a pan, so on and so forth? Or are we really talking about what these drugs do, the effect that they might have, how using multiple substances at once increases risk of overdose, of other health complications, so on and so forth? Are we having those nitty-gritty conversations? Are we allowed to? In the liberal state of Connecticut over here, every single school that I went to was very unique because each one allowed me to talk about sexual health in different ways. I had some schools where I couldn't even bring condoms to show people how to use them, how to put them on, anything like that. Other schools already had that in their health services to where they were like, yeah, you can go on in and you can show them. We even have like woodies, which for those of you who don't know that term, it's literally like a wooden, like phallic shaped device. So looking honestly like a dildo for you to be able to show how to properly use an external condom, right? Along with that, very rarely do you hear anyone talk about internal condoms. So really, like, what are we talking about with safer sex practices? How are we talking about substance use? That's very, very, very important. And it really determines how youth are going to engage with you as providers, as well as how they engage with one another and drugs in general, right? Because if you don't know anything about it, it's really hard for you to know the risk. If someone just says, this is risky, okay, but how? So, numbers for my numbers, folks. I think that, like I said, we have a lot of fears around what are youth doing. We're seeing, unfortunately, youth that are engaging in drug use, at younger and younger ages. We are unfortunately seeing overdoses rising for young people. And it's something that we need to be discussing, right? But let's also ground ourselves in some reality on how much that's really happening. Because what the reality is that nicotine vaping, cannabis, and alcohol are always the highest percentage of substances that are actually being used. Nicotine vapes as well as cannabis vapes have really, really, really dramatically increased in the last few years as they've become more accessible, right? And as well as how they've become targeted and marketed more towards young people. It's also just a lot more accessible, right? You can't smell it as much. There's no actual combustion part that's happening where there's like a flame and smoke for smoke detectors, so on and so forth. But just for some stats, I won't read every single one off of this, but for nicotine vaping, you've got eighth graders, about 12% of them, this is from 2022, that have reported nicotine vaping in the last year. Alcohol use, 15.2% for eighth graders, 51.9% for 12th graders. And cannabis is actually a bit lower than you might think, right? It's lower than nicotine and alcohol for 8th and 10th graders. But for that 12th grade age, we obviously see kind of like quite a jump in that senior year, right? And you have to also think that for some folks who are in 12th grade, they turn 18. So depending, in Connecticut now, everything's moved to 21, but for 18, you can access nicotine legally. You know what I mean? Now, it's difficult to find a lot of research on other, as they say, other illicit drug use. So this is when we're talking about maybe like psychedelics, benzodiazepines, stimulant drugs, things like that. So not just opioids. And when I say stimulants, I don't just mean like cocaine, crack, meth, but also like Adderall, right? Adderall, Ritalin, Vyvanse, things like that. Not as high as you might think. It's still existing, absolutely, but only about, so you got 4.9% of eighth graders, 8% of 12th graders reporting that they used an illicit drug other than marijuana. And then when we're getting into narcotics other than heroin, so think like Vicodin, Oxy, Percocet, things like that, it has increased slightly for 12th graders from 2021 to 2022, but it's still 1.7%. Of course, we may not like seeing a number at all for that. I mean, I'll be frank, I understand that. It's very difficult for people to understand that youth are using drugs, particularly when we're thinking about opioids. But still, it's really only about 1.7% of even 12th graders, and lesser than that as we get younger. So it exists, but it's not as intense. And of course, this isn't even talking about all the other mixtures of drugs you can do, right? Like people will take DXM called robotripping, which is Robitussin. That's why they call it robotripping, because DXM is an active ingredient in Robitussin, and people can utilize that. People use other like over-the-counter, I'm seeing that in the chat right now, perfect, like other over-the-counter things that folks are engaging in, right? We now see things like, You have like poppers, which are sold as like video cleaner, things like that. Or you have spice, which is a form of K2, a synthetic cannabis, things that are sold as quote potpourri. But really what they are is a synthetic base for a drug already, which is not regulated, not studied, and also a heck of a lot more dangerous because of all of those factors. I'd like to make a particular note when it comes to LGBTQIA plus youth, because there are many disparities with both HIV and substance use, even amongst the youth population, right? This doesn't just apply to adults. But about 1 in 5 LGBTQ students report experiencing sexual violence in the past year, compared to 1 in 10 of their heterosexual classmates. 1 in 5 versus 1 in 10. So think about the type of things that LGBTQIA youth are facing that maybe their other peers are not, that are impacting risk behavior that they might engage in, right? Self-soothing behaviors, self-medicating behaviors that we might engage in. You know what I mean? Transgender, gender nonconforming individuals, youth individuals, pardon me, experience higher rates of mental health challenges and substance use, presumably and understandably so because of the negative impacts of what it's like to live at that, like live in that body, in their community, in this world as it is today. We would like to think that there's been many strides, against different stigmas, biases, stuff like that. But the reality is it's not reduced that much. And we have seen a skyrocket in legislation specifically attacking youth that are transgender, that are queer, so on and so forth, not just adults, but specifically children. Specifically children. And this has detrimental impacts to our health, to their health, and to their future. So we have to look at that. We have to have culturally competent providers to actually have access to care. Just because you're a provider that provides a service doesn't mean that you're actually quality at it if you are not looking at your biases, how you are able to reach certain people, what are you able to do, so on and so forth, right? Because you're comfortable with the position, but most people coming into it are not comfortable talking about this. I can talk about sexual health, drug use, sex work all day. It's not uncomfortable for me, but it's normally quite uncomfortable for the people that I work with. Now, also not going down, but also kind of like looking in even further at disparities that we see. There was a study that showed that over half of Black LGBTQ students felt unsafe at school because of their sexual orientation. At school. So we're not even talking about home. We're not talking about the community, any of that. Simply at school, where folks are supposed to be able to receive their education, right? Have accessibility to that. Over 40% of them said that they felt that way because of their gender expression, and over 30% said because of their race or ethnicity. And a 2017 study showed that the prevalence of substance use was about 2.5 to 4 times higher for transgender youth compared to their cisgender peers. So think about why that might be. Why might people have access to that? Why might people feel the need to do that, right? The need to self-soothe, the need to self-medicate. Think about the different specific harms that certain communities are facing. We really, really, really have to focus on that intersectionality because you have to look at the whole person. We can't simply look at just the substance use, right? We can't simply just look at the sexual behaviors, for example. Why is that happening? We see a lot of studies that are being released about the very real health impacts that like minority stress, for example, have. They call it like minority stress model, like the impacts that has on our physical health as well as our mental health. I could talk about harm reduction forever, but just for a quick overview for folks. So what is it? If you can take away anything from this today when it comes to what harm reduction is, I really, really want you to divorce yourself from the idea that harm reduction equals syringe, that harm reduction equals Narcan. Those things are tools that are incredibly powerful in harm reduction, but that is not all of what harm reduction is. Harm reduction is literally the reduction of harm. That is what it is. You can apply it to everything. Anything in your life. Drinking water is harm reduction. Wearing sunscreen, not texting while driving, wearing your seatbelt, all of it. Look at it as how you can reduce harms to the community as well as the individual when folks are engaging in risk behavior. So you have this marriage of public health strategies, right? The reality is harm reduction really got its legs in the AIDS crisis in the 90s. You saw syringe service programs popping up because we saw that as a surefire way to reduce HIV transmission by getting people their own supplies so they don't have to share. Earlier in this presentation, you saw me share the statistics on just how often people are sharing supplies. That's often because they don't have access to stuff on their own. Many people would engage in healthier behaviors if they had access, right? So a lot of these things come out of inaccessibility. Beyond that, you also want to look at how it incorporates different things. When we're talking about substance use, harm reduction ranges from safer use techniques, managing use, to abstinence. Abstinence does not live on an island by itself, separate from harm reduction. That is false. Abstinence is a form of harm reduction. Harm reduction is a wide toolkit that people take what they need as they need it over time, right? Our needs change over time. And depending where you are, it's going to be different, right? So abstinence is something where for some folks, they realize, you know what, I actually do need to abstain from this specific drug or this behavior, or maybe all drugs, right? That can be a form of it. You don't have to separate the two. I see this way too often where they go harm reduction or. No, it is all included because abstinence is a reduction of harm, but it's not the absence of it. You can abstain from drugs and still engage in very risky and like detrimental behaviors to your health, right? You can still have terrible diet. You can still have terrible relationships that you're engaging in, so on and so forth, right? Another huge part with this is that it's talking about meeting people, accepting them, and engaging them on their own terms. We are not in here to swoop in as saviors and save folks from themselves. You are there to meet with people and motivate them and work with them, collaborate with them to see how they can feel empowered enough to make informed decisions, even when we don't agree with those decisions, even when those decisions scare the living crap out of us. I want them to be informed. If you're going to do that thing, I want you to know the ins and outs of what that means if you do it. And not in a scary way where I'm shoving it down your throat, but in a real way. What are the consequences to that potentially? What are the risks to that potentially? Harm reduction as a movement. Again, like I said, it's so much more than just harm reduction equals syringe or equals Narcan. Wonderful life-saving tools, but that's not the only thing. So we look at public health and social justice. There is no way that you can look at public health disparities and not talk about social justice. And I do not mean in a buzzword sense. I mean in a very real, tangible sense. We cannot talk about health disparities without talking about how they come to exist, the ways that we build systems up to strategically exclude certain people, to make it inaccessible to other folks, to push other people out, and so on and so forth, how we criminalize them, putting people further into harm's way. So you really, really need to look at the intersections of where the people you're working with exist at, because it's going to be unique for every single person. I don't care if you only work with youth. Every single youth is different. Every single queer person is different. White person, Black person, brown person, Asian person, no matter what it is, everyone has unique needs that you need to look at when we're talking about treatment. So some things that it's not. This is something I got thrown in my face and still do to this day in this work. This is not a way for people to avoid personal responsibility. I think oftentimes harm reduction gets this rap of like, oh, you coddle everyone, you breathe, you bring them into your warm embrace and you just give them what they need and you never tell them anything bad, anything like that. No, what it is you're coming and meeting people in a humane and compassionate lens. You recognize them as autonomous beings, even as youth, who have knowledge, right? Who have insight, who have the ability to develop self-efficacy. We should be pushing to develop that self-efficacy. So low threshold services allow for people to make that small incremental change. They allow for youth to talk with us about topics that they might not talk with other people about. The very act of accessing services in the first place demonstrates that willingness to engage in healthier behaviors. If you come to my syringe exchange that I used to work at, right, and you're coming in, you're bringing your supplies, and then you're getting new ones, that's already showing me that you want to have safer use, that you don't want to discard your things, like in the trash or on the ground, stuff like that. You're bringing it back to me. And even if you're not, I can work with you over time on how can we get that? Are you living in a situation where you have to hide your use more? You work with the people to figure out how you can help reduce those barriers. This also isn't enabling people or, quote, keeping sick people sick. The reality is that the majority of referrals from a syringe service program specifically are to recovery programs, evidence-based interventions. The drop-in center that I ran, for example, we had more than just supplies for safer drug use. We had clothing, we had hygiene products, we had HIV, Hep C, STI testing, we had a wound care clinic that came in, we did COVID vaccinations, COVID testing. I had self-defense courses for folks that were living outside. I had specific self-defense courses for sex workers and their unique needs. Food donations for the whole community, referrals for ID, health insurance, cell phones, housing, detox as well. They are hubs that contain so much valuable things than just the supplies. But oftentimes they get watered down to just being the supplies that they give. And it's so much more because it's also engagement. It's human to human engagement. And no matter where someone is in kind of like a spectrum of, let's say, motivational interviewing, like pre-contemplation versus contemplation, you're engaging with me. It's a path to continuous engagement, and that's what I want. I don't want anyone that's just off by themselves with no one to talk to. I've had folks where it takes them 6 months to do more than just come in, give me their info real quick, take their stuff and leave. That's okay. Sometimes it's a long game, right? So some other forms of harm reduction. Again, like I said, it's not just substance use, physical health, mental health, public health in general. For example, when COVID first started, oh baby, 4 years ago, right? We're coming up on 4 years exactly. We had access to masks. We had access to hand sanitizer. We were giving out tests for free. Think about how inaccessible all of those things are now when they were given out for free so much. Seatbelts as well, designated driver programs. Those are very common around holidays and colleges, like, for example. When I was in college, one of the things that I used to do was the group that I was a part of, which was a peer education group for substance use. We would do safer rides for free. So on like big party weekends, we would do things where it's like, you can get a safe ride and we'll pick you up and we'll bring you where you need to be. Substance use, we have naloxone, for example, also just using less, changing your route of administration. Think about mental health, right? Access to medication, access to therapy and counseling that's affirming for you as who you are, right? This looks very different depending where you are. Like if you're in a small town and you only have one provider. And what if that one provider has a lot of implicit biases? That's not accessible to you. Just because it exists doesn't mean it's accessible to everyone. Your physical health. Do you even live in an area where you have access to a store that serves fruit and vegetables? Or is it one of these food desert type places where you only have a Dollar Tree that has like less than 16% of the food there, actually including fruits and vegetables? Most of them don't even have it at all, right? Condoms, birth control, exercise. Do you have insurance so you can go to the doctor? All of those things. Meaningful engagement. What does that mean? So we're not responsible for rescuing the participant. I say participant because that's what I was kind of trained and mentored with. We always use program participant. For you, it may be client, patient. If you work in housing, tenant, you know what I mean? But we're not responsible for rescuing this person. They are responsible for their own life, including youth. If you are going in with a savior complex, you are going to burn out so hard, so hard. You're also probably going to have a very difficult time establishing appropriate boundaries with the people that you're serving. And I don't say that to be rude, but it's to be honest. This work can be very difficult to maintain those incredibly important boundaries. But when we don't maintain them, we're doing the people that we're serving a disservice just to make ourselves feel a bit better. So we're not responsible for their outcome. What we are responsible for, though, is checking our biases, for participating and collaborating with them in different interventions that may be responsible for healthier outcomes. So what does effective and participant-centered or youth-centered involvement even look like? This is when we really have to look at how we look at young people instead of infantilizing them so much. You don't want to adultify them too much, where we make them seem too adult, right? However, we got to stop pretending that children don't have ideas and that they're not autonomous beings themselves who are able to have these types of conversations, particularly if they're engaging in these behaviors, because they are. So you need to explicitly recognize that young people have unique value and perspective. We were all young people once, but all of us here today were not a young person in February 2024. It's very different. Look at what COVID did for young folks, right? None of us had to live through that as a young person. So there is no way that I can sit there and tell a youth that I know more than them because I lived being a young person. You have to really work with them. You have to include their voice. Truly, truly, truly. If you're doing programs where you're working with youth, look at capacity building support. Do you have youth advisory boards? Do you have it where folks can be able to get paid for their services, for the things that they're doing? So on and so forth. Are your policies and practices like actually accessible to youth? And if they're not, how can you overhaul or reconceptualize them so that they are? Things that are going to help with making your your meaningfulness, your engagement meaningful, pardon me, is developing a trusting relationship. You see any positive change and harm reduction all the time because you've got to. You really got to look at any positive change because the reality is sometimes you're working with folks who are engaging in incredibly high risk behaviors. So you celebrate those little things at the time because guess what? Most people aren't. Most people won't get celebrated for anything until they go into complete abstinence-based recovery and for a long time at that. Okay. I've worked with programs that try to say, yeah, we really value youth, but we value peer voices so, so much. And then I go, oh, so you employ peers? And they go, yeah. And I'm like, oh, okay, what does that look like? And they say, well, they have to have at least a few years of abstinence-based recovery. And I go, well, that's really narrow. Why? Where I worked, almost everyone, including up to the ED, was a peer, someone with lived experience. I also supervised people that were actively using, actively injecting drugs. They were capable of doing this work. Okay. It is able to be done. I have worked with youth programs where everyone there is like a youth peer educator for substance use. It can be done. It might be terrifying to you, but it's not impossible and it's incredibly valuable. So again, look at this process of mutual learning. Young people have stuff to teach us as well. I am not the end all be all of knowledge. No one here is, right? Not at all. You have to really honor someone's personal experience, including the impact of what stigma has done for them. You need to implement a harm reduction approach. This is difficult. I understand, particularly for young people, but we really need to stop over pathologizing everything, over diagnosing everyone for something that they did, so on and so forth. Those things can be valuable, and people can have seasons of their life. Working with them to do that. So not also over pathologizing ambivalence, assuming that because they're not ready to talk about it, that they don't care. That's not true. They may not be ready to talk about it yet. You might have to utilize a heck of a lot of motivational interviewing. I know that's most of what I did. Really, really working with them, meeting them where they're at, listening to them actively to understand what are the things that they're ready to talk about? What are the things that they want to talk about? You have to be honest and authentic. You want to maintain appropriate boundaries, but be honest and authentic. Young people, very quick to read, right? People who use drugs absolutely have survived based off of making those quick judgments, things like that. People are going to be able to tell by your tone, your facial expressions, your body language. Check yourself. And if you do mess up, if you do misspeak, put your foot in your mouth, I've done it a million times, learn to apologize. That's very, very powerful. Young people often do not get apologies from adults. They're told to just deal because they're young. So value what they bring, identify what motivates them, help them develop that self-efficacy. They're going to need that in life, not just for sexual health and substance use, but in general. Now, the center in New York City, I'm probably going to drop the link because honestly, I just think that they're fabulous. They did a presentation with National Harm Reduction Coalition's Lighthouse Learning Collective. Lighthouse Learning Collective is a program that is specifically at the intersection of LGBTQIA health and harm reduction. I highly, highly recommend, if you haven't heard of them, you check them out. because truly we need to look at these intersections that people exist within, right? So the center has this wonderful youth treatment program that's built with different components with so many peer workers there. They have individual counseling. They have online recovery groups that are not just abstinence-based. They have specific groups for LGBTQIA youth. They have psychiatric services. They have group activities. They have family member activities where you can integrate the family into treatment, right? They're encouraged to. They have case management and they incentivize attending those groups. Incredibly beneficial. And in our last minute together, we talked about this harm reduction approach, safer use, managed use, abstinence, but also looking at drug use as a continuum. You are not destined to stay in chaotic drug use for the rest of your life if you had a period of it. Most of us will ebb and flow somewhere along this spectrum in our lifetime, right? As well as this continuum of drug use is going to look different for each substance. I might use, nicotine all day, every day, right? I might be doing that. But cannabis, I may smoke with my friends every now and then, socially, things like that. Maybe I was interested in what cocaine was like, so I tried it once. I experimented and I was like, oh, not for me. It made me too anxious. I don't like it. This exists for every single drug. You need to break that down. If you are just lumping all of it together, you're really doing a disservice for yourself as well as for the people that you're serving, because it doesn't help break down what does what, right? If I find that stimulants really, really help me focus, maybe that needs to look at like what ADHD might look like for me, right? So on and so forth. If I realize that alcohol makes me feel more calm in social settings and I feel like I can talk with friends more. Learning what drugs do for people is really important in order to help find other healthier mechanisms that may be able to fulfill that as well. Risk reduction includes condoms, lube, access to PrEP, knowing your status, changing your route in administration, meaning going from injecting to smoking or to snorting, safer smoking kits, getting vaccinated, not using drugs alone, learning how to use drugs more safely, setting an alarm in between stuff. As providers, having bathroom policies to help reduce fatal overdoses, Narcan, sterile supplies, loving people, right? Fentanyl test strips. Again, you'll have all of these slides, but just like different strategies for how we can reduce it, right? You can get down to it, including injecting into different parts of your body is safer than others, learning those types of things. Like I said, I'll give you my contact info. So if you ever have questions on this, I have a plethora of resources, toolkits, online stuff like research, things like that I'm happy to share. I don't know everything. I have a wonderful network of people that know a lot more than me that I could happily connect you to as well. And lastly, drug setting. Understanding that it's more than just the drug use itself. You have to look at what type of drugs are we using them? How are you using them? What is your mindset when you're using them? And where are you physically? All of these things interplay together when we're talking about safety and reduction of risk with this specifically, particularly with our youth, right? Because the setting is going to vary quite differently when you're like in your bedroom by yourself and your family doesn't know, or your mindset is, I'm really, really, really nervous, or my mindset is, my friends are kind of pressuring me into this. Harm reduction services is so much more than this. This is just a slight breadth of what they are, right? It's more than just overdose prevention. It's safer sex materials. It's referrals, referrals, referrals. No one can be everything. We need one another, okay? We really need one another. We can't keep working in silos. Not every center can do everything, and that's okay. Thank you so much for your time. I know we've got Q&A time. I can stay after a little bit past 1. I want to be mindful of your time. I very much value it, but I can't stay a little bit after, so here we go.
Alex, thank you so much. That was extremely engaging and powerful and very informative. And there was a lot of great enthusiasm and engagement in the chat. So we appreciate everyone who was able to communicate with one another. So with that said, I don't want to take away from our Q&A time. We do have a few minutes. I want to start with, there is one chat in there's one question in the Q&A, and we'll start there. So just as we go through this, please, if you have any questions, go ahead and drop them in the Q&A. There is one virtual hand up, and we will get to that person. So if you would like to ask your question in real time, you can raise your virtual hand, and we will give you an opportunity to ask your questions to Alex. So, Alex, I just want to say in the Q&A, you had mentioned this early on when you went over the rates for 2021, the HIV rates, and how not everyone reported. But this question specifically wants to know, how accurate are the 2021 HIV rates considering the COVID pandemic's impact on healthcare access? So not just self-reporting, but because of COVID.
You see, well, if you're looking at the screen, you're probably seeing my face, which is, like I say, data is gold and drastically needs to be taken with a grain of salt, especially since 2020. Because in 2020, what you saw reported by the CDC was this drop in HIV. People weren't getting tested. So I would say that honestly, anything that you look at with data, assume it's more. Never assume less, assume it's more. When it comes to like what kind of percentage of variability, I would say, I don't want to misspeak and give you like a hard number. I would just say assume it's more, because we've already got 1 in 8 people who don't know that they're living with HIV, never mind people who haven't had access. I'll be frank, the first HIV positive result I ever gave to someone in a testing setting actually came to me who with test results from Quest Diagnostics. They received an email from Quest Diagnostics about their results that said that they were positive for syphilis and HIV. They did not know how to read that documentation. No one reached out to them. The doctor's office who referred them to Quest and gave that referral said, here's a list of referrals for HIV infectious disease doctors. This person had no idea how to read any of that, right? So it may get reported as a number there, but then that person wasn't connected to care. So I would just say that's what it says. I would assume more, not only because not everyone's getting tested, but because ain't no way everyone who did an at-home test is going to tell the people when they call back maybe that it was positive because of that stigma and that fear. Most of my friends that are living with HIV that are young people didn't tell anyone for a long time, or at least for a period of time before they connected to care. They needed that freak out time.
Okay. So at this time, I'm gonna open the line. So if Kaylee, you're still ready, I'm gonna go ahead and open your line. So Kaylee, whenever you're ready, you want to ask your question?
And if not, it's okay. You can drop it in the chat. I know Zoom functions can be funky.
I think you did such a great job. You may have answered their question, but we do have some other questions in the chat. The struggle we have in Portland, or is it that it is hard to keep stock, or organizations not having enough funding of harm reduction supplies? Where and how do we get these supplies, i.e. needles, safe smoking kits, etc.?
First of all, Portland. Y'all have been through it. Y'all have been through it. You have had like some like big wins in harm reduction and not. I'm actually going to drop a website in the chat for you. So there is a group, first of all, for naloxone itself. There's something called Next Distro, which does mailing. It mails you naloxone for individuals. Sometimes they work with orgs. However, Remedy Alliance / For the People is a phenomenal program that works with individuals, works with organizations. I just put it in the chat on getting safer supplies, as well as getting naloxone access to these folks that don't have the ability to get it, right? That don't have funding, that have been cut off, like cut out, stuff like that. It's also founded and run by some really badass harm reductionists who have been in this field for decades. Truly like movers and shakers in this work. I cannot recommend them enough. And thank you for doing work also for those of you in the rural sections, because it is very, even more so difficult, because then you're working with folks who everyone knows everyone. So there is no anonymity. And then here's the link for next distro as well. I just dropped.
How do you mend the barrier between starting a syringe exchange in my rural area versus the fear of the local police?
Unfortunately, you got to work with them, to be honest, because the reality is if you like even if you get approval from your city, like, because first you have to get approval. So you have to get approval like from the city health department to do it. You can do things. Harm reductionists have been doing this, honestly, like off the books since the beginning of time. Okay. People have been doing syringe exchanges, stuff like that before they were legal and still when they're not legal in many states. I say that just to be real. And of course, I don't want people to put themselves at risk that they're not comfortable with. So first you would really need to like work with your city to see if it's approved, as well as then finding a place where you're able to set up. I will tell you right now, business owners are going to be the worst, most annoying. You think police are going to be difficult? Business owners, they love to complain about harm reduction. So finding your allies in that, like someone that will let you set up in their parking lot is huge. And honestly, churches have been huge for it. There's a program called COSI out of Maine, which is the Church of Safe Injection, because churches have been good for like guerrilla harm reduction themselves, which is we want to keep people alive, even depending on, like how you feel about it. Police, I would then just say like working with them, you may have to front load a lot of education, which might be very infuriating to do for a while, right? But you really, if you're doing it, I highly recommend going from the lens of taking some of the load off of them, as well as affirming the real trauma that occurs for first responders. Um, front loading that, like, I know that you see the same things I'm seeing, and we actually do have very similar desires, which is to see less of it. They might want to see less drug use altogether. Well, guess what? They want to see less deaths. They want to see less harm being caused. And that's a symbiotic goal. But you're going to have to end up realistically, especially rural, you're going to end up having to work with police, which in harm reduction, I know is like not lovely and desired, but that's how I keep participants safe. Because if I have cops roll up on me that say, "What are you doing here?" I can say, "I'm able to be here. I'm legally allowed to be here. This person gave me permission to be here," because you don't want them harassing your clients.
I currently work in Eastern Oregon, and we are having trouble coordinating referrals among harm reduction, treatment, and behavioral health organizations. What is the best advice to try to get them to work together and break down those silos?
A lot of repetition when talking with one another. I did so much like, can I come and talk with you and have a conversation? Symbiotic goals all day, every day. Like, what do you need that I can help with? Like, what burden can I relieve from you by you allowing me to like do this part of it? Like, really kind of sussing out who are your allies in harm reduction, because when it comes to referrals, you're going to have to build a Rolodex of your own, which is like, we don't want to blindly send people somewhere and then you send them to like the most stigmatizing place. Now, if that's the only place that exists, you want to give your folks the heads up. So I've done a lot of meetings with people, just like, can I talk to you about our program? Can I learn more about your program? And then repeating those conversations over time, even when I want to yank my hair out from the things that are being said, but just trying to increase education and reduce stigma. So that way the people that we're serving are getting better quality care, because I can't do everything. I'm not an infectious disease doctor. I'm not an APRN. I can't prescribe medication that you need, for example. But I can try to be an ally to those folks to help you.
And do you have any information about PEP access for youth and young adults who use drugs? As in, how likely were they to seek PEP services?
Ooh, I don't have any, see this from the hand movement. I don't have any statistics on the likelihood of them receiving it, but I will absolutely look into that some more. So if you want to email me, we can maybe collaborate on finding some information on that. Or if anyone here, for example, does, that would be great, because PEP is awesome. You just go to the emergency room for that. Now it can be billed if you're using your insurance, it's going to be billed through insurance. If that's through your parents, that can be looked up. So that gets a little bit more dicey, depending on like how stringent your parents are at looking at claims, stuff like that. But for PEP, you can just go to the emergency room. And you don't have to disclose anything that you don't need to. You don't need to say that it was from like injection drug use. You can say that you had unprotected sex, for example, if you're really concerned about like being outed. Of course, I would love it if people could feel like they could open, like, like be honest with their provider, but sometimes they're not ready yet. So talking about maybe ways that people can say that as well to still get that service.
Great, thank you. And is there any guidance recommendations on harm reduction programs working with law enforcement?
Oh gosh, yeah. Or you mean like what I recommend or like how many programs that have done it? So there are programs that have done it. In fact, there is actually there's a group called LEAP, which is Law Enforcement Against Prohibition, which is a group of folks who are either active or former law enforcement officers who are against drug prohibition completely. So those programs do exist. You do have folks that have worked in this and seen, you know what, I saw it from the inside and this did not work. Like how we're doing it now didn't work. But I can absolutely connect folks with other resources. I'm blanking on like certain groups on the top of my head, but that's something where if you reach out to me, I can definitely send you more links, give you some more kind of like data research stuff that's more helpful. I hope that's not too vague of an answer. Oh, thank you, Mason. I'm not surprised they watered it down. Like, I'm just saying, like, I'm not surprised it got watered down. But just in general, like, you don't want to work for them, but you have to end up working with them oftentimes.
Well, Alex, thank you so much. You have addressed all the questions in our Q&A, and there are no additional questions. And we really want to thank you for taking these few extra minutes to answer those questions. From those who were able to stay with us on the call, we just want to say that we're looking forward to the next session in our series, which will be on March 1st at 12 p.m. And that's going to be breaking the cycle, redefining HIV and STI prevention for individuals with substance use disorders. We'll be sending out the post webinar email, which will include the evaluation and information for the next session. And we hope that you all can join us. So again, thank you so much, Alex, and everyone that had joined us today. And we wish you all a wonderful day and weekend.
Thank you all so much for your time, for spending this hour with us. And seriously, don't be afraid to reach out. My contact info will be in the slides too. So I mean it. Thank you.